Thank you so much for joining us tonight for our discussion on PCOS and menopause. I am delighted and honoured to be joined by Dr. Vikram Talulikar, and who is a leading expert not just in PCOS but also in menopause, and well recognised for your expertise. Thank you so much for giving up some of your evening to have this really important conversation with us tonight.
Thank you, Rachel. And it's always a pleasure to do any webinar for Verity. Thank you so much.
Thank you. Would you like to just quickly start by introducing yourself, where you're working, what just a little bit about your background?
So I work as a menopause specialist at UCLH Hospital, which is really primarily just based a little bit of research in terms of women's health for the Institute of Women's Health at UCL. And I do a bit of a private practice that's mainly linked for women's health and menopause.
Great, thank you. We're going to dive straight into some of the questions that we had submitted in advance of this webinar. We had an overwhelming number of questions, well over 100. So what we've done is grouped them together. Apologies for the background noise. But please, if you've got a question that comes up, if it's related to what we're talking about, or if you want to just ask a general question, pop it into the chat or into the Q&A. We will do our best to get to as many of them as we can. However, as I mentioned, we have been inundated with questions. So hopefully we shall cover off your question or something related to it. So let's get started by talking about our understanding and expectations. Firstly, can you just give us an overview of what perimenopause is, menopause, how people know that they're entering into that stage, and then we'll kind of dive into the PCOS specifics.
So I think what we're really going to talk about is the stages of menopause transition. There has been so much talk recently about menopause journey, how it's very individual for every woman. So menopause happens in 3 stages. The first stage is the perimenopause. This is when hormones first time start changing. Let's say before perimenopause, most women will have a regular menstrual cycle. And I'm not specifically talking here about PCOS. We'll come to that in a second. But generally, one would be expecting to have a regular menstrual cycle, a normal FSH, LH, and an estrogen level. The first stage when hormones start changing is the perimenopause. So the FSH and the LH fluctuate widely, go up and down. And the testosterone is slowly coming down. Along with this will come the changes to menstrual cycles. So periods may become frequent, or the cycles will become long and periods will be infrequent. And that stage again will show up with some symptoms. So women will start noticing some of the symptoms of lack of estrogen or the lack of testosterone at that point. Then that stage will usually last for 2 to 5 years for most women, and then eventually periods will stop. So the gap will increase more and more and more, and the periods will stop. Once the final period has happened, about 1 year later, technically you diagnose menopause. So somebody has been 12 months without a period, having had periods before, one would say you've gone through menopause. And from that point on, 1 year since the last period till end of life, so we're talking about 30, 40 years of a woman's life, is post-menopause. And that's why so much focus on the menopause now, because we want to make sure women live healthy, good quality life in those 40 years and protect their long-term health.
Great, thank you. And that leads me very nicely into probably the question that we had about 30 or 40 times. If I'm not having periods because of my PCOS, how do I know I haven't had a period for 12 months and then are in menopause?
So that is a challenging thing, both for healthcare professionals and I'm sure for so many patients or women who will be listening today. Symptoms of PCOS and perimenopause or menopause overlap. And the periods being one symptom where they're irregular or they're absent. So we know polycystic ovaries itself can cause oligomenorrhea, long gaps between periods. One may go without periods for 6 months, even a year or longer. And in that situation, it becomes very difficult to go by the menstrual pattern to diagnose menopause. And you have to look at the whole picture. You have to look at if there are any symptoms of menopause or perimenopause. For example, when you go through the perimenopause or menopause, you will start noticing lack of estrogen symptoms. Now, these symptoms can be head to toe. It can be the hot flushes, it can be the night sweats, it can be difficulty sleeping, good quality sleep becomes an issue. It can be physical symptoms such as eczema, dryness of skin, vaginal dryness, painful intercourse. It can be mood changes, sudden mood changes, fluctuations, irritability, which cannot be explained otherwise. You can have joint pains, muscle aches all over the body. You can have migraines or headaches. So I'm just mentioning a few common ones, but there are almost 35 symptoms of menopause. And then if you look at the age, somebody getting to their late 30s, early 40s, late 40s, they start noticing these symptoms. Although they may not be having periods because of PCOS, it will mean that the symptoms are now suggesting you're transitioning from PCOS and lack of periods to perimenopause, lack of periods, and then finally menopause. So you really go by symptoms. In some situations, we may need bloods, but in the majority of women, it's the symptoms and the whole picture of how they present at the time when you're expected to go through menopause. That will define how we diagnose perimenopause from PCOS.
And you mentioned about symptom overlap, and we heard a few then that you mentioned that are common with PCOS: mood swings, irritability, sleep difficulties. We obviously have that link between sleep apnea. So how more complicated is it to diagnose, and what should someone do if they're suspecting actually these are maybe not PCOS symptoms any longer and menopause symptoms?
So again, I think it's important to mention these to your health professional, because usually what can help here is charting your symptoms, looking at your period pattern. Has it changed further? So if you were having oligomenorrhea, you were having periods every 2 months, 3 months, 6 months, is the gap now actually decreasing? Has there been a change to that pattern? Is the gap widening further? And is that tying in with those symptoms, which may be new onset? So we know, for example, women with PCOS may have fatigue, may have low libido, may have low energy levels, may have mood fluctuation swings already. They may notice hair growth, hirsutism, chin hair, acne, oily skin. All of those, as you rightly said, can also be because of perimenopause and menopause. You can get all those symptoms, but you'll usually see that there are new onset symptoms here. With the changes to the periods, there are new onset symptoms happening. And then you put 2 plus 2 together to say, this looks like it's a transition now from the PCOS pattern to the perimenopause. Now, in some women, as I mentioned before, you may have to do blood test. Now, this is to differentiate the two conditions where the FSH levels will be going up in perimenopause while they will be normal in reproductive years with PCOS. And you may have to rule out some other conditions, the thyroid, the B12, the anemia, which can also coexist. So it's the holistic clinical picture, new onset of symptoms, changes to the menstrual pattern already, which was irregular, and sometimes the blood test, which will then nail the picture that this is transitioning now from PCOS to the menopause.
And who is best placed to help with the diagnosis? Is it GP? Is it a referral into secondary care?
It is both, because it's individualized. You can't make blanket recommendations because everyone is a little bit different in terms of their symptoms. They may have had other medical issues in the background, which might make it complicated for the GP to manage, for example, menopause or perimenopause with complex scenario. So I think the first thing for the patient is trying to monitor their symptoms, 3 months, 6 months, keep a log of everything that you're going through, because that information is critical for your primary care physician or your hospital doctor. Once you've got that information, see your GP. They will be the first person to help you. Your specialist nurse or a GP will be able to make sure that you get the right support. And in complex scenarios where there is difficulty diagnosing, there is challenge, there are medical morbidities where HRT or non-HRT options may be tricky, they will then refer you to the secondary care.
Great, thank you. So let's talk a little bit more specifically about PCOS and menopause. How does menopause affect PCOS symptoms, and how do PCOS symptoms affect menopause?
So it is very little research that exists in this area. Rachel, you'll probably be campaigning for this for a long time to come, and you've always campaigned about lack of research with PCOS in general. But if you look at menopause per se, there's very little out there. And in fact, the international guidelines, which were published last year, allude to that. They say there is so little evidence when you look at the menopause section in the guideline, there is very little to go by. So a lot of what I'm going to say today is based on limited evidence, limited data, our experience in the clinics, but there is plenty more to research. And a lot of what I say might change in future, but let's go by the evidence we have so far. There was a little bit of data initially to suggest that women with PCOS have late onset of menopause. So there were some small studies which suggested up to 4 years later, because we know that the average age of menopause in the Western world is about 50, 51. So it was thought that if you have PCOS, because you have more number of follicles, you have bigger number of ovarian follicles, you might actually end up having menopause 3 to 4 years later. Then based on the other studies like AMH levels, it was thought that you would have a 2-year later menopause with PCOS. And many studies keep showing this, that there is a delay in menopause in women with PCOS as compared to those who don't have it. Some studies have had conflicting results. For example, some systematic reviews which combine different studies showed there may not be the 2-year difference that the small studies found. So we haven't settled that question fully, but it's likely that given that the reserve in the ovary, the number of follicles are bigger, women may tend to go through menopause a little later if they have PCOS. What symptoms predominate? Again, it's the hyperandrogenism that comes to mind. So we know that women with PCOS will either be more sensitive to androgens, testosterone, androstenedione, DHEAS, or they may have higher levels of androgens. Both possibilities exist. And that tends to carry on in their 40s, 50s, and later on. So the one typical feature you see is women going through menopause will carry their hyperandrogenism in most situations. And that means they'll continue to have some of the adverse symptoms because of the excess androgen.
Just explain basic level, what do you mean by hyperandrogenism?
So it's the excess of male pattern hormones. So whenever we diagnose PCOS, we have 3 criteria in general. One is the lack of ovulation or the irregularity of periods. Second is a scan that shows ovaries with multiple eggs or follicles. And the third criterion is either clinically or biochemically, we should be seeing excess male pattern hormone activity or excess androgen activity, whether it's a blood test which shows high level, or whether it's excess body hair, acne, oily skin, or thinning of the scalp hair. And that's the hyperandrogenism that tends to carry on during the menopause.
Get worse or just carry on?
It carries on. So for women who have already had it, it carries on. Now, the one pattern that happens for women without PCOS, who then go through perimenopause, menopause, their estrogen level drops and their testosterone or androgen levels are relatively stable or slightly dropped. That tilts the ratio, less estrogen, but similar androgen, makes them come with chin hair or hirsutism. This is for women without PCOS. But for women with PCOS, they've usually battled this throughout their life. They've already had sensitivity or excess androgen issues. And you see that that carries on when they get to menopause. So the simple thing about it is they may need support for the hyperandrogenism that carries on, unlike women with no PCOS who may not have the hyperandrogenism necessarily. But of course, there are other symptoms. The symptoms of perimenopause PCOS overlap and could be additive. For example, weight gain. Women in menopause will often gain weight, mostly around the tummy or the central part of the body. That can exacerbate in women with PCOS because they already have insulin resistance, and the PCOS often will give them a little bit of propensity to quick weight gain. That can exacerbate with menopause. Once the estrogen levels drop, there'll be acceleration of that. So things like cardiovascular disease, weight gain, fatigue, a bit of inflammation in the background, all those conditions will be more for PCOS women to battle in menopause as compared to those without PCOS.
Great. So what I hear you saying is that we will continue to battle with the things that have always been harder for us, and it will not go away after menopause. And in fact, it might get worse.
Well, yes, and that's why the lifestyle interventions we'll talk about later on. But the point is right. Yes.
Yeah. Okay, great. Thank you. And what about the so we had a few questions from people, and in fact one's just popped up in the chat, was actually as they aged and they got closer to, you know, their 50s, their cycles actually regulated for the first time in their life. Can you please explain that? Is that a common thing for people with PCOS? And how does that
So it
affect?
is something we see, and in fact, it's something that's covered in the menopause guidelines as well. So what happens is you have a huge ovarian reserve, lots of follicles, lots of hormones during the early reproductive years, say 20, 30, 40s. And then as you come towards the 40s, the overall number of follicles goes down, the ovarian activity, hormone activity drops. That causes a rise in FSH from the brain. And you often find at this point that the long gaps women had in their cycles, because the FSH is working faster and the number of eggs and the hormone activity is decreasing, the cycles become short. So often women will find, oh, I've had always very long irregular cycle. I'm now starting to see them every 4 weeks, 5 weeks, 6 weeks, much more regular than I was used to. And that's not uncommon. So about 1 in 3 women might show that their cycles actually regularize and regulate more as they get to perimenopause, and eventually the gap again increases when they stop in menopause.
And if someone finds themselves in that scenario, how important is contraception? Is it, if they're not wanting to have a perimenopausal baby?
Absolutely critical. So at different times, of course, during the PCOS journey, contraception is very, very important, critical, but particularly times when somebody is on anti-androgen medication, you have to be very careful with contraception. Somebody taking metformin or GLP-1 agonist medication for weight loss happens and your periods become more regular, you're more likely to conceive. That's another situation where it's very important to be critical with the contraception. And similarly, in perimenopause, this is a time when you may not expect pregnancy, but actually you might start ovulating more frequently. And it's really important you're looking after contraception at this point. So it's a good point raised.
Great, thank you. Right, let's talk a little bit about HRT treatments. There is a lot of discussion within the PCOS community around adding hormones into your body when you feel like your hormones are already out of whack. When we talk about menopause treatments, we're talking about HRT, so hormone replacement. What is the role of HRT for PCOS specifically, and what type is best?
So as a general rule with HRT, it's a treatment for symptoms. If somebody goes through perimenopause, menopause, and they start experiencing symptoms which are impacting their quality of life, there may be new onset symptoms or worsening of existing overlapping symptoms, which we talked about. HRT can help. It's one of the options, besides a few lifestyle and non-HRT options. Hormone replacement therapy basically means giving back estrogen, which is declining, giving back the progesterone to protect the lining of the womb primarily. And for some women, this persistent low libido, low energy may also benefit from testosterone replacement. Now, HRT usually, and at the moment, we usually use estradiol, which is one of the favorite preparations for estrogen because that's body identical. And you often use either a progesterone or a dydrogesterone, which are the two common types of progestogen, which we combine with estrogen. 3 important things with PCOS. 1, go to the lowest effective dose because yes, you already have lots of hormonal issues and imbalances in the background. What you want to give is the minimum effective dose that keeps your symptoms at bay with the right amount of estrogen. But also remember that women with PCOS have a lifetime increased risk of womb cancer or endometrial cancer. It's always there because of the imbalance in estrogen progesterone. So when we do HRT, we have to be extra careful, very careful, that we give you enough progesterone alongside the estrogen to make sure the womb lining remains safe and healthy. So that's the key.
Just to clarify on that point, so even after a woman has stopped her periods, she's no longer shedding her womb lining every month or 50 days, or whatever her situation might be, there is still and maintains for the rest of her life an increased risk of endometrial cancer.
Yes, I mean, we don't have data specifically evaluating that risk in after perimenopause, which is why I said some of what we say is we extrapolate from the reproductive years to the post-reproductive years. But imagine somebody with PCOS transitioning into perimenopause and having HRT. One could argue that their hormones will still be slightly different to somebody without PCOS, and they may have a slightly higher level of androgens aromatizing to estrogens in the body, which may mean their endometrium is more sensitive to excess estrogen in the HRT. So the critical bit here is to make sure you're not cutting down on any progesterone as part of HRT that would expose a person with PCOS background to a higher risk of endometrial cancer.
Great, thank you for clarifying. Let's just quickly talk about what types of HRT treatment there are. People hear about pills and gels and so on. What patches? What are they in a nutshell?
There are many ways of taking estrogen: oral tablets, patches, gels, or spray, or even implants under the skin. Progesterone as oral capsules, you get in the patch, or you can get a Mirena coil or intrauterine system device. For women who have thrombotic risk factors, so they have high BMI, or they have blood clotting issues, so they are already diabetic, or they have high blood pressure, or have had any kind of blood clotting issue, for them, it's always good to avoid oral estrogen or oral progesterone, because they can go through your liver, increase your blood clotting, and the HRT can be risky because it will increase your risk of blood clotting. So we always go for patches, gel, spray, or we go for capsules of progesterone, which can be fine, or progesterone through a patch or an intrauterine system. For women with no thrombotic risk factors, who are otherwise carrying along with no medical problems, diabetes, hypertension, any other problems, they can even have oral HRT as well as all the other transdermal skin options that I talked about. So there's a wide choice there. It depends on what your symptoms are, whether they are systemic or vaginal. It depends on what you're aiming to suppress, what your medical history is. We will look at all that to choose the best estrogen-progesterone combination for you.
Thank you. We have a question in the chat, which is someone that was, her periods only stopped at 55, which the doctor didn't believe might be possible. Now 2 years without periods, but the GP is refusing to prescribe HRT because she's not ticking enough symptom boxes, and weight gain is a big concern. What might be happening there? What symptom boxes do people need to tick for HRT?
There are no hard and fast symptom boxes to tick, to be honest with you. I think it's a holistic assessment. So some women may have very mild or very little number of symptoms. Other women may have number of symptoms. Some may have very infrequent symptoms. Others may have hot flashes, sweats, or other symptoms round the clock every few hours. So I guess no one sort of situation fits everyone. Even if you have some symptoms which are mild or infrequent, but they're affecting your quality of life, they're impacting on your day-to-day work or life, there's no point withholding HRT because it would still help improve quality of life. So I guess it's probably going back to the health professional to say this is impacting my quality of life. And even if there is high BMI or there are medical issues, you can offer somebody HRT that would be through the skin, that would be safe for them. So I guess it may be a question of making that dialogue again with that particular health professional to say, I am being impacted by symptoms. There's no reason I can see here that there's a contraindication for HRT. Of course, we can't give individual advice on the webinar, but as a general rule, unless you have some contraindication, you would be fine to have HRT. You don't have to tick particular box as such.
Great advice. Thank you. And so I would just add, and it applies to any aspect of medical care. If you're not getting the assistance and help that you need, if you're not feeling like you're being listened to, then you always have the right to change doctors and to ask for a second opinion. So that might be something also to explore. What about treatments when there are other conditions involved? Obviously, sadly, PCOS doesn't live in isolation. And so someone might have endometriosis, adenomyosis, other conditions affecting hormones. and PCOS. How might that add complexity to the picture for them?
It does. As you rightly said, PCOS will usually coexist with other gynecological or medical issues. And that has a major bearing in terms of what do you do to treat somebody's menopause symptoms. For example, there may be medical issues which may mean HRT may not be safe. They have some significant blood clotting issue. They've got multiple cardiovascular morbidities or problems, in which case one may say non-HRT options will be best for you. But for others, there may be gynecological issues, endometriosis, adenomyosis being some where you have to be very careful with the dose of estrogen, because estrogen often stimulates endometriosis or adenomyosis, while progesterone is the one that counteracts the endometriosis or adenomyosis. Some may have had a hysterectomy, in which case you might only have to give them estrogen. But if they have had hysterectomy for endometriosis, you would still have to give them progesterone to prevent the recurrence happening. Some may have fibroids, which can grow with HRT. So if they are big fibroids, you have to watch them with HRT, have regular monitoring to make sure they're not growing too big. Others may have small fibroids, which you can have a bit of monitoring and then leave them alone because they're unlikely to be growing significantly. So the medical issues, gynae issues will have a bearing on the type of HRT you use and what dose or what particular route that you choose for HRT.
Thank you. We actually had a few questions as well that came up around what if you've had a thermal ablation and you have PCOS and are entering into that stage of life? Further complexities added?
So again, here the diagnosis becomes challenging because you can't go by your periods. It'll be the symptoms, how you feel. And then occasionally someone might offer you bloods, but it's really the symptoms that will determine for me that you're going through perimenopause, menopause. And one would then offer you non-HRT, HRT options. Remember, with ablation, you can have HRT, but it's important you get both estrogen, progesterone, because we don't know how much of the lining of the womb may have been left behind in pockets, and we don't want it to grow. So it will be combined HRT for you. But again, see your specialist health professional so they can advise you correctly.
And you've mentioned a few times around the blood test. What is the blood test that they use to test menopause?
So menopause is characterized by high FSH. Once the estrogen levels drop, the FSH will go up. Traditionally, 2 levels of FSH more than 25 have been classically diagnostic of menopause. And we use that, say, people with premature menopause, early menopause, below 45. We often do the test to make sure it's definitely menopause, not something else. In women who don't have periods, either because they have a coil or ablation, or they have history of PCOS with a long gap in their periods, where it becomes challenging, and clinically you're not able to certainly say this is menopause symptom, you can, of course, do bloods to help your diagnostic accuracy. And if you see a high FSH, that kind of ties in with your perimenopause, menopause diagnosis.
And a hysterectomy, what do we do?
So if somebody has had a hysterectomy, depends for what reason. If they've had a hysterectomy, they only need estrogen. Let's say if they want to go for HRT and not non-HRT for their menopause symptoms. Estrogen only HRT tends to be more safer than the progesterone, because estrogen only HRT, we say, is not associated with the long-term breast cancer risk, while the estrogen progesterone combination is the one that increases the long-term breast cancer risk with HRT. It's very little, very small increased risk, but nevertheless, it's the combined HRT. So if somebody has had a hysterectomy and they don't need progesterone, they don't have endometriosis or previous endometrial cancer, then estrogen only will be fine. If they have a uterus, that's when you have to give both estrogen and progesterone.
Thank you. One of the questions in the chat, when I was prescribed gel HRT, I was told to take my blood pressure weekly. I never had issues with blood pressure previously, even though I had a high BMI. This was concerning. I didn't take it, even though I had awful aching inflammation. I had very high levels of testosterone, and during perimenopause lost a tremendous amount of strength. Is that normal? What would you prescribe to a menopausal person in a similar situation? Obviously, caveat for everybody, we can't give personal medical advice here, but let's take the theme of high blood pressure monitoring for menopause and how that might impact on treatment pathway.
So high blood pressure in menopause, The worry here is that high blood pressure says that there is a cardiovascular risk factor and it can impact on your kidneys, on your heart, the risk of stroke becomes high. So before you start HRT, we will always like you to first control your blood pressure. And if it's been fine and you start HRT, transdermal forms of HRT, for example, patch, gel, spray forms of estrogen or the oral micronized progesterone, won't increase your blood pressure. It's not shown to significantly increase anybody's blood pressure. If you found after using the gel your blood pressure went up, it would have been coincidental. It's unlikely that the transdermal estrogen has caused it to go high. And if you continued monitoring it over a time, you will find that it actually stabilizes. But if you have high blood pressure, then it's always good to first make sure you're controlling it with some medication or lifestyle intervention, and then add on HRT in a transdermal estrogen form. That should work well. Women with PCOS tend to have higher levels of testosterone throughout life. We know that. And if you have the high levels of testosterone, then remember that when you get to the menopause transition, everybody has a little bit of slow decline in your testosterone. In the background, everyone starts declining their testosterone levels around the age of 30. And it's a tiny drop, 1%, 2% every year. And then the levels stabilize post-menopause because it's not just the ovaries, but the adrenals who also produce the testosterone. So if you have symptoms of lack of testosterone, such as low libido or low energy, then sometimes we add testosterone to estrogen, progesterone, HRT. But you might be the one who will be always sensitive to high levels of testosterone, in which case we might have to actually combine HRT with anti-testosterone medication. So a lot of women I treat for PCOS will have spironolactone for hair growth or high testosterone effects. And alongside they will have HRT with estrogen, progesterone. So you're kind of taking both problems on board, blocking the androgen and then giving estrogen, progesterone. For others, they have low testosterone symptom. So you give testosterone and estrogen, progesterone. Everybody is different.
It's incredibly complex, isn't it? Really, I can understand why there needs to be that secondary care specialism support here. And where should they go to? Gynecology, endocrinology, both? Depends.
That's a difficult one. If I say gynecology, endocrinologists will kill me. If I say endocrinology, then all the gynecologists will be angry with me. I think that
Tell them.
it's basically a combination of both. I think it's best that you go to your trusted health professional who
GP.
then can often refer you. So it's GP or you have a known gynecologist or a known endocrinologist. Go to them first because they will be able to talk to their colleagues or do a specialist referral to the next person if they are not in the capacity to help you. So I think it's usually a multidisciplinary care. That's really the key here.
Multidisciplinary care for PCOS, that is the holy grail, is it not?
Absolutely.
We wish. Okay, so going back to kind of treatments, we've talked about the prescription treatment that is available. Are there any effective non-hormonal alternatives?
Okay, so I'm going to go rapid fire here for the
Yeah.
interest of time. Menopause symptoms per se, whether PCOS or non-PCOS, you can manage with lifestyle. Mild symptoms may respond to lifestyle. So making sure you exercise at least 150 minutes if possible in a week, something that you enjoy. Eating healthy, no prescribed diet, just anything that is healthy. So Mediterranean type of diet as far as possible. If you can include some phytoestrogen, soya, tofu, pulses, beans, grams, often contain weak estrogen-like activity, could help with mild symptoms. Exercise, diet are really important, even whether you take HRT or not, because they are the pillars for the good long-term health. Often there is increased risk for diabetes, so you'll have to again watch your diet and make sure you're physically active. And then comes the role of complementary therapy. Some women do acupuncture, some women do complementary therapies like herbal therapies. There's no good medical evidence for that because often conflicting studies, limited data. So we don't recommend them medically, but some women do find it useful. CBT hypnotherapy is very good for symptoms like flushes, sweat, sleep, anxiety. Often CBT hypnotherapy does a good job and it doesn't carry any major side effects or problems. So it's often something you can always try as a non-hormonal treatment. Then we go to non-hormonal medical options. You have antidepressant therapies, whether it is SSRI, SNRI, citalopram, sertraline. You've also got venlafaxine. You've got a bladder drug called oxybutynin. The problem with these is, yes, they can help with mood and anxiety and some flushes and sweat, but they do have their own side effect. So we tend to reserve these for women who can't take hormones because hormones may be much better at alleviating symptoms. So women who have contraindications and can't take hormones, then we go down the route of non-hormonal treatments. Remember, PCOS itself has a risk of depression because of various situations, body image issues. It can be because of the experiences with healthcare and society in general. Depression can be a risk with PCOS long term. And often it's important to recognize it, screen it in time, offer psychology, offer CBT help, and even antidepressants, but watch for a side effect of weight gain. That's the key. There are novel medications called NK3 receptor antagonists, which were licensed in UK last year. And these are mainly for hot flushes, night sweat, and sleep. They are non-hormonal, so can be used for somebody who has contraindication for hormone. So far, we've got experience for 1 to 2 years, and they are effective. They need liver function monitoring. So you need to have liver enzyme test before and after for the first 3 months to make sure it's safe for you, and then you can continue it long term. So there are a number of non-hormonal options there in terms of menopause symptom management.
Right, I'm going to ask a few follow-up questions. One, you mentioned about an increased risk of type 2 diabetes in menopause. Obviously, with PCOS, we carry a greater risk of type 2 diabetes anyway. Is that compounded post-menopause, or was
Again, the data are poor again. We don't have specific studies concentrating on this. What it appears is if somebody has high BMI, then the risk gets compounded. So if you have PCOS, you have high BMI, you find that the risk becomes more. If somebody just has PCOS, but their body weight doesn't increase, then you find that the risk becomes comparable after the age of 50. That's what the preliminary data suggest.
Mm-hmm. And you mentioned about ensuring with the last treatment that you mentioned that got licensed. Just remind me what that was.
That's the NK3 receptor antagonist. It's called fezolinetant. And there's a
Great.
new one licensed called elinzanetant.
Thank you. So you mentioned with that it's important to have a liver test. There is a known risk with PCOS of fatty liver disease. Is that connected? Is that at greater risk?
So good point. Again, very common to see fatty liver with high BMI, diabetes, high lipids. All those can add on to the fatty liver and sort of metabolic syndrome. It's not a contraindication for use of the fezolinetant or NK3. So because you could have a chronic fatty liver with slightly raised liver enzymes, which has been there for years. It's not active liver disease. If somebody has active liver disease and their enzymes start going up, and that's when usually you would say this is not a medication for you. So you need specialist advice if you already have a fatty liver and you're contemplating taking the NK3 receptors. But otherwise, per se, fatty liver is a common problem with PCOS. And again, the management usually is diet, exercise, and in some cases, metformin may help in that situation.
That was the next question on the list. What about metformin post-menopause?
I use a lot of metformin, but again, it's an underutilized drug. It's got very good insulin sensitivity action. It's traditionally been not very well used even in the reproductive age group, say women in their 20s, 30s, 40s, were usually not given metformin as freely as it should be because it can improve ovulations, improve the cyclicity. For some women, it helps with fertility. But the most important bit is it will help with insulin resistance, the weight management. It will help to prevent any cardiovascular inflammation from progressing. So I tend to be proactive. I tend to recommend metformin to women at every opportunity, even early stages of them considering the medication for various reasons, whether it's menstrual, metabolic, or other problems. And hopefully we will see more people using it because again, the international guidelines now recommend metformin more liberally as we were used to in the past.
Yeah. We've had a question around, are there any supplements / amino acids that you could say help with PCOS? I'm not sure if they mean PCOS with menopause or just generally.
The straight answer would be no, other than supplement of vitamin D for your bones, because you do lose bone density during menopause, whether you're PCOS or no. So, good vitamin D supplement with calcium rich food. And magnesium is another supplement which helps some women with sleep. Other than those two, I don't recommend any supplements, whether it's amino acids, collagen, or inositol. We simply don't have good quality data. They are effective for everyone, and we simply don't have long-term safety data. So I don't recommend any of those.
Just before we move over to the next section around kind of symptoms and quality of life, we've had a number of questions come in about effective weight loss for PCOS generally, but also post-menopause when it's harder to lose weight. Are there anything available, a recommended diet, other treatments, etc., that are effective with PCOS and menopause particularly?
So I think, Rachel, you might have covered this in one of your other webinars when I think Dr. Ibarra came and talked about the GLP-1 agonist. I won't go into too many details. I'm not a dietitian myself. The simple thing is we don't have any evidence that one particular diet is linked to weight loss, because all of us are different and we may react to different diets differently. Eating healthy, small portion, Mediterranean simply is the best advice. Equally, metformin can help alongside your lifestyle, exercise, and diet. Some small data to say inositol helps with metabolic side of things, but not enough to recommend inositol as a strong medication or a supplement. GLP-1 agonists are the new therapy. So whether it's Mounjaro, whether it's semaglutide, or the Ozempic, there'll be women who may want to choose this as a treatment. And again, it depends on what your expectations are, whether you've got your lifestyle around you optimized to make sure that when you come off the medication in future, you don't have a rebound weight gain, for example, which is a worry with some of the GLP-1 agonist. So there are various levels where you might have to approach weight loss depending on what your expectation, how much weight loss, what's the long-term safety, are you optimizing your lifestyle around you, even the final option of bariatric surgery for those with very high BMI or medical complication. It's a webinar or a topic on its own, but I think the best way to start is to approach your health professional and see which is the level that you want to get to based on where you are. And each option has its pros and cons other than the lifestyle, which is always going to be there.
Just realized I was on mute. Thank you very much. I'll take a quick moment to just plug our next webinar. We're having a follow-up webinar with Dr. Ibarra to dive even deeper into GLP-1s, so Mounjaro, Ozempic, etc. So if you are interested, do have a look at our website or our social medias for that link. And just lastly on that, we talked a little bit earlier around loss of strength, for example, and you've mentioned around staying active, being healthy, and that helps. Does that mean, therefore, that strength training would become even more important during this time of life?
Absolutely. So whether it's for the bone loss, whether it's staying active and healthy, whether it's the sarcopenia, muscle loss, because as the hormones decline, the testosterone is gradually going down, the estrogen is fluctuating and then sharply going down, women lose a lot of their bone density. They also find their muscles become weaker. It's all part of perimenopause, menopause. So the best thing to do there is lifestyle intervention. So vitamin D, calcium in food, weight-bearing exercise, running, jogging, skipping, anything that puts weight on your body. Strength training, resistance exercise is excellent for bones and muscle. So if you can do that as much as you can, even if it's little and it fits into your daily or weekly schedule, you enjoy doing it, try to make it possible that you don't take it as a burden, that will help you lifestyle-wise to keep your bones and muscles active and in good shape, but equally it will help from metabolic side of things.
Okay, thank you. Lots of questions coming in about metformin, and that again is a webinar topic in and of its own. But very quickly, is metformin the only off-label medication used for insulin resistance for PCOS? And what are the risks for when doctors are resistant to prescribe it?
Well, metformin is a relatively very safe medication, including it's now being used for fatty liver, as I said before. There were always concerns about metformin, but practically for most women, it's very safe. It's usually used in a dose of 500 milligrams daily. and it can have some unpleasant GI effects, diarrhea, constipation, nausea when you start it. But they're self-limiting, they go away after 2-3 months, and you can slowly go up the dose, or you can use what we call as modified sustained release preparations, which is slow release. And these will usually help you get along with the medication better. I certainly tend to use it for anybody who has period problems in terms of oligomenorrhea or gaps in periods, or they're starting to put on weight. Weight gain is starting to become an issue or is already established. Those with high lipids or high glucose in terms of HbA1c or insulin resistance rising, the lipid profile becoming abnormal, that's the time to act. And that's when metformin would be very useful. And you can continue it into your 20s, 30s, 40s, even longer post menopause. Now, it's important we change people's attitudes to the metformin. I know a lot of GPs or a lot of hospital specialists may not prescribe it. I mean, it may not be their to-go medication. But I think with the guidelines now becoming more disseminated, with attitudes changing towards PCOS as a life course condition rather than just for fertility, more people will be willing to prescribe metformin in future.
We're campaigning for it. So from yeah, let's hope in the near future. So let's move into kind of symptoms and quality of life. How would someone, I guess, manage additional mood swings and fatigue and brain fog and weight gain that might come? We've touched a little bit, quite a lot on this already, but can you just summarize how they might manage that?
So again, if it's down to the PCOS itself, or is this now something new onset that's happening with perimenopause, menopause? Either way, again, lifestyle will be key. Making sure you're physically active, you're eating healthy. If it's the psychological mood aspect of it, you can consider seeing your health professional, getting referred for CBT, psychotherapy, psychological support is really key here. That doesn't help, you have medications, whether it's SSRI, SNRIs for mood fluctuations, for depressive thoughts, for low mood. Going step ahead for menopause-related psychological symptoms, it's best to go down HRT route rather than SSRIs. So having the right HRT with estrogen, progesterone combination would be the best in terms of any psychological symptoms related to menopause. Then again, things like fatigue, important. If it's menopause related, HRT will help. Testosterone replacement may help in some. But equally, remember, fatigue could be other reasons. It could be anemia, it could be B12 deficiency, it could be simply lack of exercise. And all those need to be corrected with lifestyle, diet. If it's anemia, it's iron supplementation, or B12 deficiency, then it's B12 injections. Thyroid may be often a sort of contributing factor, making sure you have thyroid assessed if the fatigue persists. So it's a holistic picture rather than just one therapy that will help you to know what is the source of these non-specific symptoms and deal with them one at a time.
And we discussed around hirsutism, for example, and the androgen symptoms getting worse. If someone is taking medication for, to treat excess hair or hair loss, are there any contraindications for HRT treatment on top of that?
You can in fact combine most of the anti-androgens with the HRT. So for example, the commonly used anti-androgens are spironolactone. You have finasteride, flutamide. We don't tend to use cyproterone as much now because of thrombosis risk with age, but it's the spironolactone, the finasteride, flutamide can be combined with HRT. Remember, with the last two, you need to monitor the liver enzymes, while with the spironolactone, you need to check your potassium levels, especially if you have kidney conditions in the past. Remember again that anti-androgens will mainly take care of hypertestosterone symptoms, while the HRT will help with those, but will be really for the other symptoms of menopause. Important again to remember that there are some pills, the combined pills or the progesterone-only pill like Slind, which is a new one, which also has some anti-androgen action. So if you're in the age group where you're below 40 or below 35, specifically no medical complications, and you want to take a pill or you want to take a progesterone-only pill or a combined pill, there are specific ones we like, which tend to be anti-androgenic more. So again, talk with your GP or a health professional who will be able to guide you as to the choice of the right hormone treatment, which is anti-androgenic.
Thank you very much. Time has gone quick. We've got 10 minutes. So let's talk a little bit about long-term health risks and how we have elevated health risks with PCOS, cardiovascular disease, sleep apnea, fatty liver, endometrial cancer, type 2 diabetes, and so on and so forth. How are those risks compounded when we put menopause in the equation as well?
Very true, because menopause itself is a state where the insulin resistance worsens. It's a state where weight gain happens. The lack of estrogen is known to increase cholesterol. The bad cholesterol often exposes oneself to blood vessel thickening, atherosclerosis can progress. So add that to the existing problems with PCOS in terms of hyperandrogenism, causing inflammation, cardiovascular diabetic risk. It will be some impact together. We don't have good quality data how much additive effect there is. And some studies suggest other than high BMI, the effect may be minimal, but yet there'll be some contribution to the overall worsening of cardiovascular disease, heart disease, or risk of stroke, risk of high BMI diabetes will certainly be higher. And that's why it's critical that steps are taken very early in life. And if you diagnose this at perimenopause, menopause, steps immediately, whether it's the diet, whether it's metformin, insulin sensitizers, whether it's even GLP agonist or surgery for others with very high weight, whether it's making sure everybody gets their diabetic test screening once a year or once every couple of years, making sure they have their lipid profile once every 1 to 3 years. That sort of monitoring is not happening right now. We see PCOS women, they go to their health provider, have a check, but nobody follows up. Nobody gives the information. You need to have these tests every 1 year, 3 years, because you're going to have this lifelong. It's not a condition that disappears overnight. It's basically going to be with you for life. And so you'll have to continue monitoring your diabetic risk, your blood pressure, your weight, your lipid profile. We need to get used to that sort of a long-term follow-up care, which is missing, which is really the key here.
Say it louder for the people at the back, Dr. Talulikar. Very, very important message there. We had a question here which I don't understand. I'm sure you will know what it is. Do you recommend berberine? Maybe I'm pronouncing it wrong. Berberine, Berberine.
I haven't come across that before.
No worries.
Tells you about my poor knowledge, but maybe some sort of a supplement or some sort of medication,
Sure.
which may be a trade name. If you have a generic name for the supplement or medication, let us know and we can answer that.
How long does it take to know if the HRT treatment that you have started is working, and how that might be affected by PCOS impacting on how it's working? Is it weeks? Is it months?
Usually weeks. If you start HRT for certain menopause symptoms and are expecting some change, usually by 2 to 3 weeks, you'll start noticing some change, but actually could take 3 months before you notice real effect. Some, like testosterone, may take even longer, 3 to 6 months before they start showing effect on your libido. And so therefore, give it a bit of time, persist with one medication, because sometimes the tendency is you start a particular HRT, feel it's not working, change it quickly, and that itself is a lot of fluctuation for the body. You'll never get to assess a stable effect of one particular medication. So give yourself 3 to 4 months, and if it's still not working, see your health professional back. They'll be able to change, reassess your symptoms, whether they're really due to the hormone change, and make the modification.
Where should people go to learn more about evidence-based information on menopause generally, rather than turning to, I guess, general social media for information? Where's a good resource?
Yeah, social media has very good resources, but equally sometimes not very safe and evidence-based. So I guess the best one is to go for the bodies which kind of do most of the work academically. So in the menopause space, it would be the British Menopause Society, the MREF, Menopause Research Education Fund. You've got the college, the FSRH, now called as the College of Sexual and Reproductive Health. You've got Women's Health Concern. And these are all the bodies which publish lots of patient information, which is quite evidence-based and useful. Equally for PCOS and menopause, I think Verity will be having webinars and information. But there are some guidelines which are coming from good quality NHS organizations and publications. You can always look at the name of the authors and where they work, and you will have some information which is quite useful.
We've just got a couple of minutes left, so let's talk a little bit about I think maybe your top tips for how people should, I guess, go about seeking help, how to recognize their symptoms, and yeah, we'll start with that one, and then we'll summarize with another one.
So PCOS and menopause, remember the main overlap is the symptoms, the lack of periods, irregularity, the hirsutism, chin hair or body hair, the mood swings and the fatigue often overlap. So if you're feeling that your symptoms are worsening, you're getting towards your 30s, 40s, because you can have premature early menopause, but most of the time it will be between 45 to 55. So if you're getting to that age and experiencing more symptoms or new symptoms, and you can't rely on your periods, see your health professional, track them for 3 to 4 months, because you will notice a pattern of worsening or improving or a cyclical pattern. That's useful information. And at that point, once you look at the whole picture and it looks perimenopause, menopause, you'll have option of lifestyle, non-hormonal, hormonal intervention. HRT can be easily prescribed alongside PCOS. It's important to get the dose of estrogen, progesterone right and make sure the womb lining is protected. You can also have other therapies, say metformin for metabolic or anti-androgens for suppressing the androgenic problems alongside HRT if you have to. And again, your health professional will be able to advise you on this or refer you to a specialist center.
I'm getting lots of message going, don't forget night sweats. Is there anything really effective for night sweats?
It's the HRT is the best solution for night sweats or hot flushes, which are
and
typical.
One HRT over another isn't more or less effective?
No, it's the estradiol combined with some form of progesterone. And the progesterone sometimes can also help with sleep if it's natural progesterone. So again, you're looking at getting a good form of HRT on board for these vasomotor symptoms. And if you can't take hormones, there are some non-hormonal options, which we discussed before.
Thank you very much. And just lastly, are you feeling at all positive about the future of menopause management in this country and also PCOS management and then the overlap between the two?
I think we have to stay positive. If you look at the rest of the world, and I'm not criticizing any particular health system or I'm not criticizing any country. If you look that in the West, we are in a way fortunate because we are talking about these issues. There are some countries in the world where menopause is not even talked about. Health services are not geared to deliver care for menopause. And we're trying to get awareness going in these countries or in these parts of the world. So the good thing now is we're talking about menopause, PCOS overlap. There's going to be an international draft report being published, I'm sure, next week. There are already guidelines on the issue. And I think we all have to keep campaigning, working together to say, this is a chronic lifelong condition. It's a life course approach. It's not just one-stop approach we need. We have to care for women with PCOS throughout life, from puberty right until menopause till end of life. With right campaigning, right funding, if we keep driving this forward, we've made progress, a lot more to do, but we'll get there.
Love that. Love that. One last question that's popped up, and I really want to see if we can answer this. Someone has been on the same dose of metformin for 30 years, but type 2 has recently been diagnosed type 2 diabetes and perimenopause. That would be a strong indicator for a medical review, a medication review, right?
Absolutely. Yeah. Because it now means that the insulin resistance is not being able to be controlled by your metformin. So you might need to add medication, change medication, menopause-wise. Given that you have a comorbidity, if there are symptoms, you may have to consider HRT, which is safe for you, or non-HRT option. certainly see your health professional.
Thank you so much, Dr. Talulikar. Really, really appreciate you giving up your evening to have this discussion with us. I'll just end with a very few quick points, housekeeping points. Yes, this meeting is being recorded. It will be available on our website at a later point, and we will also post snippets out across our social media channels. So if you want to watch any of this back, if you want to share a link with your healthcare professional, please do that. Dr. Talulikar mentioned there is some exciting developments happening very soon in this area. Yes, there is. Stay tuned to our social channels. Our parliamentary inquiry from the all-party parliamentary group is being published very, very soon with very clear recommendations on how the government and the National Health Service need to change to better serve those of us living with the condition. So please do stay tuned to our socials. We will ask you to get involved and contact your MPs and get them on board with the recommendations that will come out from that. So please do get involved and help us drive this forward even further. Finally, Dr. Talulikar, thank you so very much. Really, really appreciate you, your expertise, sharing it so empathetically and generously with us. And thank you very much. We'll speak again soon.
Thank you so much, Rachel. Thank you, everyone who gave your time. Thank you very much.